Signs and symptoms of preterm labor include uterine contractions that are occurring about every 10 minutes, and these may be with or without discomfort. They may feel like mild menstrual-like cramps, especially at the beginning, felt low in the abdomen. Constant or intermittent feelings of pelvic pressure is also associated with preterm labor. Back pain, any rupture of membranes, change in vaginal discharge, especially if it becomes blood tinged or bloody, and abdominal cramping. The strongest predictors for women who may go into preterm labor include those who have multiple gestations, if they've had bleeding during pregnancy, if they've had a history of other preterm labors and births, they're at higher risk. Preterm labor is associated with infection. So preterm labor is described as labor that happens after 20 weeks gestation up until 37 weeks gestation. These contractions will need to be documented to be at least 4 into a 20-minute period or 8 contractions in an hour. Cervical change or dilation will also be a positive sign of preterm labor. And usually the change is equal to or greater than 80%. Tocolysis means that we're using medication to help stop labor. Common medications used for this is magnesium sulfate. Breathing is given sub-Q, while magnesium sulfate is an IV medication. It's a continuous drip. Procardia is usually given orally. It is also used to decrease blood pressure, but also slows contractions. And indomethacin may also be used to help slow labor or stop labor. Interventions for preterm labor include positioning. Usually the left lateral position is recommended. Increased fluids, such as IV fluids. Lab studies will be completed, which include a complete blood count, a C-reactive protein. Cultures will be done both vaginally and of urine to check for infections. And they will test a fetal fibronectin to check for lung maturity. And ultrasounds also help diagnose preterm labor while also ensuring fetal well-being. Premature rupture of membranes. There are several risk factors that's associated with this. These include low socioeconomic status. Tobacco use is associated with preterm rupture of membranes. A low body mass index, infection, previous histories of preterm rupture, hydramnios, multiple pregnancy, urinary tract infections. It can be associated with an amniocentesis. Placenta previa and abruption, trauma, and incompetent cervix are all risk factors for preterm rupture of membranes. Preterm rupture of membranes is considered to be before there are 37 weeks gestation. Implications for the fetus include respiratory distress syndrome, sepsis, malpresentation. One of the big risk factors is umbilical cord prolapse. and compression due to that ruptured membranes before engagement of the fetal presenting part, non-reassuring fetal heart rate tracings, premature birth, and there's increased perinatal morbidity and mortality rate. Nursing care for preterm ruptured membranes includes monitoring for infection, taking daily temperatures or hourly temperatures, assessing fetal heart rate, make sure it's not becoming either tachy or bradycardic, evaluating the women or partners' childbirth for preparation and coping abilities for preterm rupture. We need to assess uterine activity and the fetal response to that uterine activity by continuous monitoring and palpation. Vaginal exams need to be limited due to the membranes being ruptured because that increases the chances of infection. We want to keep these women adequately hydrated. And they will need to be on bed rest, especially if the head was not well engaged with preterm rupture of membranes. Lots of education is needed. For placenta previa, that is when the placenta implants in the uterus in a lower area than normal. There are a few different areas that the placenta tends to be located, and we'll talk about those in just a minute. With placenta previa, these women usually will present with vaginal bleeding without pain. So there's 4 degrees of placental previa, and that's a total previa, which completely covers the cervical opening. A partial previa, which partially covers. Marginal is on the edge, and low-lying is just close to the edge of the cervical opening. Risk factors for a placenta previa include women of Asian descent, if they've had a prior cesarean section, if they've had a high number of pregnancies, advanced maternal age, previous miscarriages, induced abortions, and cigarette smoking are all risk factors. So assessing for placenta previa, or with placenta previa for the newborn, we need to promote neonatal physiologic adaptation to the new environment, immediate laboratory assessment and monitoring for hemoglobin, cell volume, and erythrocyte count is important to check for infection and red blood cells. Anticipate potential need for oxygen in the newborn, blood administration, and admission to a special care nursery. Blood transfusions are also a possibility for these infants. We need to be assessing mom's the maternal vital signs frequently, about every 15 minutes if they're not hemorrhaging, and every 5 minutes if they have an active hemorrhage. And we also need to be monitoring for contractions. Abruptio placenta or abruption is the premature separation of a normally implanted placenta from the uterine wall. There is no known cause specifically for abruption. Abruptions are classified as marginal, which means the blood passes between the fetal membranes and the uterine wall and escapes vaginally. It's also classified as central. Blood is trapped between the placenta and the uterine wall with no bleeding to be seen. And a complete abruption means that there's total separation of the placenta from the uterine wall, and there's usually massive bleeding associated with this. We need to monitor for DIC with any abruption. Cervical insufficiency, we talked about earlier in another chapter. That's the incompetent cervix that cannot hold a pregnancy long enough. It's a structural or a functional defect. The women are usually unaware that they're even having contractions. And when they present, usually they are well effaced and dilated, may even have a bulging bag of membranes. Women at risk for cervical insufficiency need to be monitored closely for cervical length. They need to be educated early in pregnancy on the warning signs of an impending birth. They also need to be told that lower back pain, pelvic pressure, and changes in vaginal discharge can also be signs of insufficient cervix or of a preterm birth. A cerclage is used surgically. It's a surgical procedure that stitches the cervix closed to help prevent spontaneous abortions or premature births. After 37 weeks have been completed gestation, the suture may be cut and removed, and the vaginal birth is permitted. Implications for multiple gestation pregnancies: there's a higher mortality rate than there is for one fetus. There's a decreased uterine growth rate, higher incidence of anomalies, increased prematurity rate, and abnormal presentations are common. Cord accidents, that means the cord is accidentally closed off or maybe around the baby's neck and is tight, and that's called a cord accident, and you lose the baby to a fetal demise. Increase in cerebral palsy rates and hemorrhage at birth or shortly after are also implications of multiple gestation pregnancies. We want to encourage these women, as far as activity is concerned, to have frequent rest periods. Sideline position increases blood flow and decreases cardiac demand. And we want to have them elevate their legs while they're in that lying position. With labor care on multiple gestations, we have continuous fetal monitoring of both fetuses, or however many there are. Usually multiple gestations are delivered via C-section. You need duplicate supplies for delivery. You need additional staff members available. And special procedures need to be enforced to ensure correct identification of the newborns. Hydramnios, again, is a congenital anomaly. Fetal malformations, swallowing, or neurologic disorders are possible. So there's two types. Chronic means the fluid increases and becomes a problem in the third trimester. Acute fluid increases rapidly over a few days to cause hydramnios. Nursing care includes sterile technique during an amniocentesis, and psychological support for the family. Oligohydramnios usually occurs post-maturity. Maternal hypertensive disorders, intrauterine growth restriction, is usually secondary to placental insufficiency when oligohydramnios is present. Fetal conditions such as renal malformations may occur. Fetal risk include fetal skin and skeletal abnormalities, pulmonary hypoplasia, cord compression, and fetal head compression. Clinical therapy includes biophysical profiles, non-stress tests, serial ultrasounds, induction of labor when the fetus is at term may be necessary. Continuous electronic fetal monitoring needs to be implemented to detect cord compression, and a possible amnio infusion after the membranes are ruptured to decrease variable decelerations and cord compression. Nursing care during the birth of an oligohydramnios mom. We need, again, continuous electronic fetal monitoring, repositioning mom if variable decelerations are occurring. We need to notify the physician or the healthcare provider immediately on any non-reassuring tracing. A non-reassuring fetal heart tracing may warrant a C-section. And we want to assess the newborn for signs of other anomalies, congenital anomalies, pulmonary hypoplasia, and post-maturity. Chapter 21, again, labor, this is labor-related complication. Post-term pregnancy is a labor complication. Post-term is considered when the pregnancy is lasting at least 42 weeks and 1 day. First-time moms are known to be more common to have post-maturity babies. Special monitoring needs to be provided. Hypotonic labor. Factors associated with hypotonic labor include an overstretched uterus, like with a twin gestation, or a large fetus. Hydramnios can also stretch out the uterus. Grand multiparity means many children. And bladder or bowel distension can also lead to this problem, as well as cephalopelvic disproportion. So hypotonic labor usually develops while active labor is going on. It's characterized by less than 2 or 3 contractions in a 10-minute period. Contractions may not be very intense, and they also may not be very uncomfortable. So with this large size uterus, they're not getting a good effective labor pattern. Hypertonic or tachysystole labor patterns are associated with increased discomfort, fatigue, stress, dehydration, increased risk of infection, placental abruption. A non-reassuring fetal tracing may be present, and prolonged pressure on the fetal head may also be a problem. So tachysystole is ineffective uterine contractions, usually in early labor, which is the latent phase. The resting tone is increased, so there's not much relaxation for the uterus in between contractions. and they can develop a prolonged latent phase, leading to fetal hypoxia. Nursing care for the patient with tachysystolic contractions includes watching and assessing those contractions along with fetal heart tracings and vital signs, providing comfort measures, changing positions, helping the mom to relax using either therapeutic touch, visualization, warm showers or baths often help relaxation. It may lead to needing sedation or pain medication to help slow contractions and allow for rest. Malpresentation of the fetus means that the optimal part of the fetus's head is not what the presenting part is. So it's any position other than the occiput anterior. This can cephalopelvic disproportion is common with fetal malposition. Dysfunctional labor and prolonged labor is also common. Postpartum hemorrhage, along with the 3rd and 4th degree lacerations or episiotomy extensions, may be performed due to fetal malposition. With the fetus, we're likely to see or high risk for meconium aspiration because of the stress that they may go through, asphyxia, shoulder dystocia, upper brachial plexus injury, and fractured clavicles are common with fetal malpresentation. Also, hypoglycemia, polycythemia, and hyperbilirubinemia are also common in malpresentations. So here are some pictures of some infants or fetuses in malpresentating positions. You can have a brow presentation. Forehead of the fetus may also be presenting with the brow. That means that the largest diameter of the fetal head is presenting into the small part of the pelvis. Face presentations as well, and breech presentations means the bottom is first, or sometimes there's different types of breeches. It could be a footling breech. A front breech is both legs up and bottom coming first. And then there's a malpresentation of transverse lie. That's when the baby has their back kind of laying over the cervical opening. Fetal macrosomia is a large baby, more than 4,000 grams when it's born. Increased maternal risk is cephalopelvic disproportion, dysfunctional labor, prolonged labor, postpartum hemorrhage. C-sections may be indicated if the fetus is at or above 4,500 grams. Shoulder dystocia may be present with a vaginal delivery of a large baby. Nurse assistance may be needed to help deliver the baby with shoulder dystocia. With these babies, we want to use continuous fetal monitoring. Any signs of labor dysfunction or non-reassuring fetal heart rate tracings need to be relayed to the healthcare provider. So a woman who delivers a large baby will need to be monitored carefully for excessive bleeding. Their uterine tone may be boggy and need to be massaged to firm more than once. We need to make sure that their bladder stays empty, and we may need to administer extra oxytocin or Pitocin to help contract the uterus. Non-reassuring fetal heart rate status. This is when you're watching your fetal heart tracings and there's a variation from the normal heart rate or baseline heart rate. It may be that you're seeing or having reported decreased fetal movements. You may see meconium-stained amniotic fluid. Fetal heart rate patterns that are warning signs would include persistent late decelerations, persistent severe variable decelerations, prolonged decelerations, and loss of variability. Other signs can include tachycardia and bradycardia, the fetal heart tracing. Treatment for these complications includes immediate intrauterine resuscitation. So to provide that, we need to correct any kind of hypotension by checking mom's vital signs, her blood pressure, and correct hypotension. And we can do this with increased fluids. We need to decrease the intensity and frequency of contractions if they are present by turning off the Pitocin. We need to administer oxygen so mom can deliver more oxygen to the fetus, and that would be by providing 7 to 10 liters per minute of oxygen via face mask. Scalp stimulation may be needed to help arouse the baby and increase its heart rate if it's bradycardic. Correction of maternal hypotension. We talked about the increase in the IV infusion rate and position changes. Left lateral, again, is the position of choice to do this. A vaginal exam is probably also needed at this time to look for a prolapsed cord. And we already discussed discontinuing any oxytocin that may be going. An umbilical cord prolapse is when the umbilical cord that supplies the fetus with oxygen and nutrients from the placenta before the fetal head or the presenting part engages in the pelvis, the cord actually comes out first, and that's called an umbilical cord prolapse. We see this on the monitor by variable or continued prolonged variable deceleration, and it may also look like just a bradycardic episode with the fetus. A vaginal exam needs to be done, and if a cord is noted, we need to relieve cord compression with gloved fingers. Use gravity to help position mom either in Trendelenburg or on her hands and knees to help relieve pressure on that cord. We're going to give oxygen with the face mask at 7 to 10 liters per minute. And we're going to prepare her for cesarean section, although she may still be able to deliver vaginally if she's completely dilated. The physician or midwife, healthcare provider, definitely needs to be notified if they haven't already been. And sometimes they may disagree on ambulation at this point, and you want to help them communicate with each other. Knee chest position to relieve cord compression again is very important. Amniotic fluid embolism is a rare complication, but it can be devastating. It frequently occurs either during or after childbirth when the woman has had a really difficult, hard, and fast labor. It can occur with a placental abruption and trauma, induced labor, eclampsia. It can happen with cesarean section and other complications with pregnancy. Signs and symptoms of an amniotic fluid embolism includes a sudden onset of respiratory distress, circulatory collapse, which you would see with the blood pressure, acute hemorrhage, signs and symptoms of dyspnea and cyanosis that also progress to hemorrhage, and then it leads to shock and death if not corrected. Immediate birth may be required in order to have a live newborn. We're going to respond to this intrauterine resuscitation as well, or if it happened afterwards, actually, by doing the same type of recovery methods that we did a little while ago discussed. We're going to administer oxygen again under positive pressure. We're going to make sure we have an IV line established with fluids. We're going to provide respiratory and cardiac support, CPR, if needed. We want to have equipment and blood ready for blood transfusion. And while we're doing this fluids and blood transfusions, we need to monitor for fluid overload. And we can detect that with wheezes, especially in the lungs. Cephalopelvic disproportion. The fetus is larger than the passageway is, or the pelvis is for mom. So fetus is not going to fit through the passageway. That's a CPD. The cause is a narrowed pelvis or tissue dystocia. Also reproductive tract anomalies. The dangers with CPD includes cord prolapse, excessive cranial molding with that head trying to fit through, damage to the fetal skull due to that pressure trying to squeeze this baby through, and damage to the central nervous system. If CPD is suspected, we want to try different positioning techniques to help increase the pelvis diameters. This can be accomplished by having the mom sit or squat. Also, knee chest position. Helping her with her legs way up to her sides and up by her chest, which is called McRoberts position, can help increase the diameter of the pelvis. Mom may automatically do this herself. Complications during the third and fourth stage of pregnancy is retained placenta, lacerations that may occur, and placenta accreta. A retained placenta happens when either a fragment, a partial, or a whole placenta remains in the uterus more than 30 minutes after delivery. There may be excessive bleeding present. The healthcare provider may have to manually remove the placenta or the piece of placenta that was left in order to stop bleeding and hemorrhaging. Failure of removing that placenta manually will necessitate surgery using a curettage to get the placenta out. Lacerations can be vaginal or cervical. You suspect a laceration when you see continuous bright red vaginal bleeding that persists even when the uterus is firm and contracted. You'll see increased incidences of lacerations with first-time moms, nulliparous, if they've had epidural anesthesia, forceps and vacuum-assisted births, episiotomies, and large babies. First, second, third, and fourth degree lacerations are possible, and episiotomies. We didn't discuss grief too much during class, but I will mention it here just a little bit. The loss of a fetus, of a baby, is detrimental to a family. Responses to grief are different. You may not ever see the same thing twice. We need to be respectful of certain beliefs and cultural practices when mourning. We want to help the people or person experience and accept their loss and adjust to their loss. And in labor and delivery, we do this by letting parents see and touch and hold their infants. If it was a stillbirth or whatever happened, we let them hold it and visit as much as possible, as long as needed, for them to get through the grieving process at this point. So bereavement is actually, the definition is the period of adjustment to loss. And no one person requires the same amount of time to grieve for this kind of loss. Stages of grief, if you remember from other lessons you may have had last semester, they go through denial. They can't believe it's actually happened. And then anger stage, when they are upset with somebody else as being the cause. It may even be themselves they're upset with. Bargaining, they'll go through a depressive stage, and hopefully finally an acceptance stage. None of these stages have a certain amount of time that is normal or abnormal, and they may not go in order. Nursing interventions, we need to prepare the family that's going to be there for the birth, what to expect. We need to support the family in viewing the stillborn and holding it. We need to teach them and provide instructions on discharge care. We need to give community service referrals. We help them with information on funerals if they want that. And we need to help make sure that recognizing the unique needs of couples with previous pregnancy losses. They come in after a previous pregnancy loss and have many fears and anxieties of going through it again. So we need to be very careful to recognize those needs.